Okay, thanks Roberta for that introduction, and Eileen, thank you very much for your heartfelt testimony. I think we can relate to that very strongly, and certainly as someone who would be seen as a grey suit or a manager, it's always very valuable to get those views, and I know you and I will be working together over the next number of weeks, but I'll probably touch on that in the presentation. As Roberta said, this is very much a double act. Paul Turley is my name. I'm the co-chair of the Regional Palliative Care Group, along with my colleague Corrina Grimes, who'll be speaking in a couple of minutes. But as usual, the Health and Social Care Board and the PHA do everything in partnership, so that's one of our key partnerships around this arrangement. I've got a couple of quotes just to bring our focus back, I think, to the patient. The first one is from William Osler. I'm not quite sure if you know that particular name, but he's a fairly eminent physician in America back at the end of the 1800s. And he's very much associated with founding the Johns Hopkins University in America. He was also a bit of a practical joker as well, so I'm not quite sure how he married palliative care and practical jokes together, but certainly he was infamous for that. And one of the things that he said was that a good physician treats the disease, but a great physician treats the patient who has the disease. I think that's a very important message to get across. A lot of you will be familiar with Cicely Saunders in terms of her involvement, and she founded the first hospice, I think, in London back in the late 1960s, and is obviously very much associated with the hospice movement and promoting palliative care to probably where it is today. And again, her quote there is about the individual and focusing on the individual. You matter because you're you, and you matter because you're at the end of life. We will do everything that we can to help you die peacefully, but also, and importantly, to live until you die. So we have a quote here in relation to palliative and end-of-life care, and it comes from the Living Matters, Dying Matters strategy, which was back in 2010. And you'll see there, you can have a read at it, but obviously the important issues for us is it is about advanced and progressive illness and about that continuum of care. It's also about an integrated approach, part of which is delivered by health and social care professionals. But importantly, I suppose it's also about support from the family. And Alan's presentation, I think, shortly will talk about compassionate community. So maybe this quote is slightly dated in that it goes back to 2010, and I think we maybe need to take that definition and discussion broader, and we look forward to hearing Alan's presentation shortly. It also then talks about some of the points that William Osler and Cicely Saunders has brought up at the end there in relation to focusing on the patient and the patient's needs right up until the end of their life. We've been very busy back at the board and PHA in terms of our processes and strategy, taking that forward. So I'm just going to highlight a couple of those things at the moment. The first one is really around the Transforming Your Palliative and End-of-Life Care initiative, which we started obviously through the TYC process, which a lot of people will be familiar with. And you'll see that through that process, working, I have to say, with Macmillan around this particular process, because they supported us fantastically through the whole TYC years. Sorry, I think I've moved on there. Through the TYC years, with again the patient in the centre of the circle, and you'll see then the different initiatives we took forward, 8 specific initiatives around the TYC programme. Again, identification, which we'll talk about shortly, enhancing access to services at home, and day hospice and how we will change day hospice. And we're in a process at the moment. I've met with Foyle Hospice earlier this week just about hearing more how they're changing and realigning their day hospice services, maybe to have more of a clinical focus through those. Support for the carers, as Andrew in his introduction quite clearly highlighted, there is a need to make sure that we support carers through this process. Palliative care pharmacy has come up as a big issue for us, and again we're working with Macmillan in relation to that, and they're taking forward an initiative with us over the next couple of years in relation to that. Ambulance came out as a key issue in terms of joining up the dots and getting people to the right places, or maybe changing the pathway so that the patient can be supported at home through rapid support services, and those are now in place. Discharge was a big issue, and obviously in terms of patient flow and the unscheduled care agenda, it's important that people are discharged appropriately from hospital, and we're very pleased that in terms of the new documentation that's been circulated now through to trusts, there is a home to die policy within that, so hopefully that will be working its way through the discharge coordinator arrangements with various hospitals. And key to a lot of all of this, as you will all know, is the whole issue about training of all the professionals and carers involved in the system, and we're taking that forward as well. Living Matters, Dying Matters is obviously our strategy document. We've been working through that, obviously. Obviously, Living Matters, Dying Matters is our strategy document, which came out in 2010. It was reviewed in 2015 by the RQIA, and they published the review at the start of this year. And I suppose we got a very positive response from that in terms of the 25 recommendations that we had to take forward. And you'll see some of their comments there in relation to there had been significant progress in relation to palliative and end-of-life care over the time period. They did highlight the strong commitment from all those who are involved, both in the voluntary sector and the statutory sector, in terms of delivering the palliative care agenda. And they did highlight that we took this process forward at a time of obviously constraints around the health system over that 5-year period, and particularly noting as well that whenever the strategy came down, it did not come down with a specific funding stream. It was something that we had to work through with the resources that we had available to us at the time. Patient engagement, again going back to getting the views of the user and the carer importantly. The All-Ireland Institute for Hospice and Palliative Care are a key partner for us in relation to that engagement. A lot of you will be familiar with the Let's Talk process, and you'll see there the details that they took forward in terms of 2012, 2013 and their engagement process and their final report. And there's a link there to the findings of that report, and that will also take you into the All-Ireland Hub, which has been noted already is a fantastic resource, and I would recommend that particular website to all here today. Just some of the key messages that were coming out from that particular Let's Talk survey. I won't go down through them all, but I will highlight the issue of sensitive communication, again, which has been noted already. And the issue around emotional and psychological support, and certainly as a commissioner, that is something that has come through to us at the Health and Social Care Board right across a range of programmes of services, is I suppose the dearth of capacity around emotional and psychological support. And I know that the Director of Social Care at the board has very much prioritised that as something that needs to go forward in the next couple of years in terms of building capacity around psychological support. So we're bringing this all together now in a process, and I've mentioned Living Matters, Dying Matters, Transforming Your Palliative Care. Obviously 25 recommendations with Living Matters, Dying Matters, 8 work streams as I've noted around Transforming Your Palliative Care. The RQI recommendations themselves came forward with a further 8 things for us to do, and we're building that in, and obviously we're taking in the views of Let's Talk. So we have a new programme, it's Palliative Care in Partnership. We launched it back on the 7th of April this year at the Pavilion at Stormont. Again, it was another one of those workshops, a bit like this one, which was nearly oversubscribed in terms of the interest around the palliative care and end-of-life agenda. So what we have now is one structure. We have one agenda around palliative care, and it is a very extensive agenda. And we've really got a clear direction, I think, now in terms of taking palliative care forward in Northern Ireland. So just in terms of the structure that we are working to, we have a regional palliative care board that's co-chaired by Dean Sullivan, who's the Director of Commissioning at the board, and Mary Hines, who's the Director of Nursing and Patient Experience with the PHA. We have a range of people around that table. We had our first meeting in April. We have another meeting of that, second meeting of that board this Friday. We've got representatives obviously from the statutory side, from the voluntary side, and we will be asking members of the user group as well to join that. Just moving down then to the right-hand side, your right-hand side, we have a service user group and reference group, and I'm co-chairing that with a service user. We had our first meeting on the 28th of September. Eileen, you joined us for that. Again, that's facilitated by our colleagues in the All-Ireland Institute. And we're pleased to have that relationship going through in relation to that, and that's working through the Voices for Care programme. I think we've got 20 people. Obviously, that's an all-Ireland approach, but we've specifically got 20 people from Northern Ireland. We had about 15 of them with us in Glengall Street, as I say, on the 20th. So a lot coming back. I'll maybe touch on that in a wee second as well. And then on the other side, then we've got the Clinical Engagement Group, which Corrina is co-chairing. And there's a big agenda around that. But specifically this year, we need to look at the palliative care workforce going forward, because obviously across a lot of issues, workforce is a major concern, and we're devoting some time to that this year. And then importantly, in terms of the bedrock of how we're taking this forward locally, we've got palliative care locality boards, and they're coterminous with the trust areas, but again, the membership is reflective of the palliative care programme board at the top. So we have everybody we need to have involved at that locality level. And again, we'll be asking members of our user group to engage and join with those locality boards. Just finally, in the centre, as I say, Corrina and I co-chair the Regional Palliative Care Group. We're supported by a team of professionals from the board and the PHA, but I would also like to acknowledge the support that Mary Curie continue to give us to support that project through Diane Walker, who's our project worker, and again, a lot of you will know Diane. The lights were on when these photographs were taken, I can assure you. This is some of our representatives from the palliative care user group. Eileen, I think you can probably see yourself there at the top there. We had a lot of, it was our first meeting. We had a lot of reaction, I think, within the discussions on the day. And I'll maybe just reflect on some of those if I can find some of the comments that came through from some of the service users. Language, the term holistic palliative care, what does that mean? I think we were asked. Well, we need to go back and we need to think about our language and how we talk to people, certainly in relation to that whole thing. The issue about communication generally, again, has been brought up, and about conversations and when conversations need to start and who needs to lead those conversations. So that's something for us to consider. One individual, Arthur, who I was sitting beside there, told me of a story around the whole pharmacy issue for him and how his life has been transformed by a change of his medication. And he had an opportunity to spend time with his GP and with a pharmacist, and they reviewed his medication, and he feels so much better. His quality of life has improved immensely. And I suppose the last concern that I reflected on in the day was a view from carers mostly, I think, and some patients, that there's this perception that this hospital that my loved one is in or we are in only works 5 days a week. It just closes down at the weekends. So we need to fix that particular issue as well. And I know from wearing my commissioner hat that we have been investing certainly in trusts to try and push out that 7-day working model. So this is going to be a very valuable group for us in terms of our programme. And we look forward to working with all the service users and getting you involved and getting your voice in terms of those agendas that we have and those structures that we have around palliative care. It's a busy agenda. There's a lot of partners within the palliative care program. I see that as a strength. I don't see it as a weakness. I've worked on a number of programs over the last number of years, and in no area is there more of a call for strong partnership working than there is in the palliative care agenda. And certainly when it comes to funding, I think there's opportunities because obviously we're in a constrained funding situation at the moment and will continue to be. But I think working with our partners, there will be opportunities in there for us to take various projects forward as we've outlined within the agenda. I'm going to hand over to Corrina now, who's going to take you through the rest of the presentation, but I think I'm going to have to be unplugged.
Thank you, Paul. I'm going to start with this slide. I saw it at an event Paul and I were at a number of weeks ago, and I think it sort of sums up the theme of today. Helping communities care for their own. Professionals are essential, but are not central. And so I suppose that is the ethos that we would support within the Regional Palliative Care Programme. It's wider than health and social care in the widest context and wider than the partners that Paul has described in the previous slide. But we thought it might be helpful just to focus on that health and social care perspective and say, what are we doing within health and social care within our partners to make sure that our processes and systems, that our services and that our staff have the knowledge and the confidence and the self-efficacy to deliver the quality of care that we expect and we feel that people with palliative and end-of-life care needs and those important to them need to have. So within the Regional Palliative Care Programme, there is quite an extensive work plan, but we thought we'd maybe highlight some of the key priority areas, let us understand the rationale behind that and what the pieces of work might be. So I suppose the overall aim is that everyone identified as possibly in their last year of life, regardless of their condition, is allocated a key worker, has the opportunity to discuss and record their advanced care decisions if they wish to do so, be supported by the correct generalist and specialist palliative care services, and that this is all underpinned by good practice tools, guidance and education. And I can hear some people maybe thinking, why are we focusing just on the last year of life? Palliative care is wider than that. I think our particular and initial focus will be on those in the last year of life because if we make a significant difference to those in the last year of life, we're impacting on a significant number of families and people across the region. So the key priority areas are around identification, key worker, advanced care planning and specialist palliative care. So in terms of our rationale, if we look at identification, why is that one of our key areas? Well, we know on average 15,000 people die in Northern Ireland every year. There was a slight increase last year. And we know that it's estimated that 75% of those people may have had palliative and end-of-life care needs. Oh, and I've just turned the slide off. But we know then if we look at our GP registers, that it's estimated that 1% of people on a GP register are possibly in the last year of life. And I suppose, notice my language, we're talking about possible and probable. This is not an exact science. Thank you. That's better. So 1% of the population, we're talking about 19,000 people. And if we look at our GP palliative care registers, we know there's between 5,000 and 6,000 people on our palliative care registers. So there's a mismatch between those with potentially in the last year of life and those people on our GP registers. So we felt that we needed to be more proactive in terms of our approach of identifying people. We have good practice tools, we have the gold standards framework, we have the SPIC tool, but we really need to get a more proactive approach to try to help clinicians and families and carers be identified and identify their palliative and end-of-life care needs. So Paul has mentioned the Transforming Your Palliative and End-of-Life Care programme, and within the programme, good practice was identified in Scotland, led by Professor Scott Murray, where Scott and his colleague, Dr. Bruce Mason, developed an algorithm, and the algorithm was based on codable data within GP practices, usually read codes, and their algorithm was fit to be run in GP practices to generate a list of people who potentially or possibly could be in the last year of life. And this list was a good starting point for the GP, the members of the multidisciplinary team, and obviously the families and the person and their families if they wanted to be included, in having the discussion about, do we feel that this person's possibly in the last year of life, and if they are, what do we need to do if there was a rapid deterioration? And so that triggered a number of good practices that we know would improve the quality of care for people in the last year of life. So this protocol is something that we hope to develop and roll out across Northern Ireland with 14 GP practices who have expressed an interest. And subject to funding, we would like to develop this same protocol across the region in 16-17. The next priority area is looking at key worker. And suppose the driver for this, Paul has mentioned the Living Matters, Dying Matters strategy. So key worker was one of the key recommendations within that strategy. And way back in 2013, a paper was developed to help trusts and providers across the region implement this recommendation. And you can see here what some of the key roles and responsibilities were. So over the number of years, there's been really good practice to try to develop the key worker, but it's reflected listening to people on a clinical level, listening to our service providers. And I suppose in the RQA review that we needed to have a more focused approach around this key worker and how can we really get it placed into practice so that it wasn't, that it was standardised across the region. So recent conversations have progressed, and it's felt that the district nurse is well placed to typically be the key worker. So we're not saying that the district nurse will always be the key worker, because there may be patients, say respiratory patients, where the respiratory nurse specialist is well placed to be their key worker, but typically the district nurse will be the key worker. And again, if you speak to people receiving services, if you speak to our district nursing colleagues on the front line and service providers, people feel comfortable with this approach. District nurses are often involved in care in the last days of life, and they feel that they would like to be involved and to know the patient earlier on in their journey, so that they're not arriving at the door in a crisis, that they've begun to build that relationship up. We also acknowledge that there's not current capacity within the district nursing service to provide this role and function. And so we're working with our district nursing colleagues and our nursing leads, both within the Public Health Agency and across the region, to identify what the capacity is and begin to put those hours into district nursing services. Albeit a small allocation has went to each of the trusts a number of weeks ago, and I think that's just the start of developing that capacity within district nursing service. So the key areas for the district nurse are around the identification, so to be part of that MDT discussion, to provide that contact, care and coordination, and I think that was a key message in Eileen's experience and also the experience that Andrew had mentioned this morning. We need someone there to coordinate. We don't need lots of professionals coming in and not having that coordinated approach. That's not helpful for the person or their family. The district nurse will also be providing that service that they always have around delivering the hands-on nursing care, and also formalising and standardising that bereavement support, which again, when you speak to bereaved relatives, that's a very significant, important element of the role. Should it be practical things like the removal of equipment to signposting for ongoing bereavement support. The third priority then is advanced care planning, and I suppose within our programme we acknowledge that advanced care planning is wider than health and social care. It's an umbrella term that covers legal, professional, clinical wishes. And again, it's a point that it can't be, we're not going to start setting up advanced care planning clinics. This is about an ongoing process, about having discussions and about people feeling comfortable about having those discussions. But from a health and social care perspective, we need to try to help not only the public become engaged in advanced care planning, but we need to put a system and process in so that professionals know, how do I do this? How do I transfer the information? So if someone has a conversation, how do we communicate that across the system? So again, with many partners, and I see their faces in the room today, we have developed a number of products to try to help both the public and the health and social care system do advanced care planning better. So the first booklet you'll see is, and thanks Eileen for the plug, is a partnership again between Macmillan and the Public Health Agency. It's a publication called Your Life, Your Choices, Plan Ahead. The second edition has been very successful because I think there was 1,000 printed 3 weeks ago and they're out of stock at the minute, so apologies, we plan to have one for everyone in the room this evening, or this morning, but we can certainly forward the link. So within this booklet, it's a public-facing booklet. It's not aimed at those with palliative and end-of-life care needs. It's aimed at all of us. And often if people come visiting to my house and I have a spare copy, you could go home maybe with a copy under your arm. So it takes you through topics around organ donation, making a will. Eileen mentioned enduring power of attorney, right through to your care wishes, things about DNA, CPR, and advanced decisions to refuse treatments. Within the booklet, there's also inserts that people can use. So there's a checklist, and I think that sort of reflects the list that you had used from your experience from London. So it's a checklist to let people think, well, what do I need to think about? Do I want to make a will? Do I want to note my care wishes? And again, it's very much person-led. The other insert within the booklet is a record of my wishes. So this gives people the opportunity to think about what are my wishes and cares, whether they're health and social care related or related to particular wishes you may want around your funeral planning. And it helps people begin to think about their future wishes. The last form within this booklet is if people have particular wishes about treatments that they wish to refuse, there's a form called Advanced Decisions to Refuse Treatment. This booklet is printed and you can order it free of charge and delivered free of charge through Macmillan website. So, and again, I think that partnership really enables this to be accessible for all members of the public. So if people then have decided that they have health and social care wishes, we have a regionally agreed form, an advanced care planning summary form, and that is the form where the health and social care professionals should communicate the person's wishes across the healthcare system. And at this stage, it is a paper-based form, but we're going for progress, not perfection. Ultimately, the items in that is codable and codable within the GP system. And we would hope in 2017-18 that codable information will be fit to be transferred electronically through the key information summary, which is a part of people's, part of the, I'm trying not to use acronyms, ACR, Electronic Care Record in Northern Ireland. We've also done work on DNA CPR. There had been challenges. Each organisation had their own DNA CPR policy. There was queries and concerns that if a notice is completed in one organisation, does it transfer to another? So we now have a regional approach. The documents in draft is going through final legal review. We will be doing a piece of work with our service user and carer group around the whole advanced care planning work, and that will be part of it. So we'll hope to have it issued to the region in the next number of months. And last but not least, we have an advanced care planning operational document. I've talked through a number of products, so this document really tries to explain what the documents are, when do you use them, how do you use them, where do you get them, and I suppose it's a Health and Social Care Guide to Advanced Care Planning. The last priority area is looking at specialist palliative care, and Paul had mentioned this, that we need to look at our workforce. So specialist palliative care will provide care not to all of our patients, but to a subset of people with palliative and end-of-life care needs. Through previous work, there were a number of challenges identified around access to specialist nursing at weekends, palliative care consultants at home and advice out of hours, allied health professionals in the community, specialist palliative care workforce nearing retirement age, and I suppose a lack of palliative medicine consultants. So the piece of work, 2 pieces of work that have been going forward. Again, there has been developments within the southern area. So there is now a complete multidisciplinary team with nursing, allied health professionals and social work, which wasn't the case a number of years ago. And Macmillan have also begun a process within the West. So some of the gaps that had previously been identified have now been resourced in that partnership approach between the West and Macmillan. So we're bridging some of those gaps, but we still need to look at the workforce in further detail. So there will be a workforce review piece. It's just commenced over the last couple of weeks, to look at the workforce in terms of medicine, nursing, physiotherapy, occupational therapy, dietetics, speech and language therapy, social work and pharmacy. And I think the point to note for this, previous workforces have been medical workforces or maybe other unidisciplinary workforce. This is a workforce review looking at an interdisciplinary approach, because I think we need to start delivering our care in this interdisciplinary approach. And again, it might help from the family's point of view and from the patient's point of view, in terms that we're having this coordinated approach from the outset. Paul has touched on some of the other work streams in his presentation. We've mentioned the Macmillan Pharmacy project, again to address some of the practical and process issues around access to medication. Some of the issues don't happen that frequently, but they have a massive impact on families when people can't get the particular drugs they need to get, maybe in and out of our situation. Project ECHO. Project ECHO was a tele-mentoring model, and we talked about we need to ensure that our workforce have the skills and confidence. So Project ECHO, as I said, tele-mentoring model. It was developed in New Mexico for people who don't know about it. And it's where it uses video conferencing to bring experts and people with who want to have their knowledge improved together using video conferencing in like a hub and spoke model. Northern Ireland Hospice were the key drivers, and were the first ECHO participants with their specialist palliative care teams, and have shown great improvements in terms of increasing knowledge and self-efficacy of staff. Last year we also had Project ECHOs for nursing homes, and that will continue this year. We'll also have for an ECHO for carers. And again, if people are part of organisations where they think their carers may be involved, or people from a carer's perspective would like to be involved in this ECHO, it's something that we're beginning recruitment for, so we'll be keen to talk to you about that. For domiciliary care workers as well, because often this is a group of staff who may not get as much support and supervision and education as other members in the health and social care team. That will be going forward in the next number of months. Monitorings and measures, and again, we're delighted and we're looking forward to Professor Norman's talk about monitoring and measures. There's a lot of work been done at a trust and organisation level, and we're speaking with our department in terms of what are going to be our key outcome measures to measure impact of palliative and end-of-life care. The NICE Care of the Dying guidance have been endorsed in January, and we're working through again with all our partners to ensure that this guidance is implemented. And again, through the programme and through that partnership approach, we have taken a new approach of how this NICE guidance has been implemented compared to other NICE guidance that come down through endorsement. So it's definitely improved partnership approach and will affect, I think, real change quicker. Paul's mentioned the day service model, the hospital discharge, the ambulance service, and I suppose what underpins it all, and I suppose what today is about that continued raising awareness. So things like Palliative Care Week, these types of events, and just getting ourselves, our professions and our communities more empowered about raising awareness. I think finally, I just want to, Paul started with 2 quotes, and I just want to finish with 2 quotes. One of Mary Carey's campaigns a number of years ago had this strapline, and it's always stuck with me, and I don't know if people have seen the video. your last moments should mean as much as your first. And I think we have a culture where we are quite open on talking about births and the first year of our lives and celebrating it. But sometimes we just are not that, we're sort of on the opposite end of the pole when we're talking about people in the last year of life. So if anyone hasn't seen that video clip, I'd look it up, I would recommend it. So I suppose that's the point, and particularly from a public health point of view, we put an awful, and rightly so, investment in time and energy into the first year of life, and we need to do the same for those in the last year of life. And I think the reason why we need to do this is because how people die remain in the memory of those who live on. Again, another quote from Dame Cicely Saunders, but I think it's very poignant to us all. And you talk to people who have been bereaved 6 months ago, 6 years ago, or even 50 years ago, and how people died really does live on. So I suppose the overall aim of our programme is just to improve the quality of care that we can and improve the experience of those, and those important to people with palliative and end-of-life care needs. Thank you.